Hi there, I'm Dr. Jane Lee. You guys know me as a general surgeon. I'm one of three partners, Dr. Kincaid and Dr. Bove, and we do the general surgery around here. So today we're going to be talking about postoperative ileus mostly, and then a little bit about why it's important to get our patients to get up and move around. So we're going to start off with a question. This is the first time I'm doing this, so please bear with us. But apparently you're going to be able to participate. All right, so the first question is, what is post-op ileus? So is it a name of a Greek god of bowel surgery? Failure of passage of enteric contents through the small bowel and colon without evidence of bowel obstruction? Is it the inability to walk after surgery? Is it another name for postoperative bowel obstruction? So I'll give you guys a couple seconds, and it looks like, wow, you guys are super smart. You got that one right off the bat. So yes, post-op ileus is failure of the passage of enteric contents through both the small bowel and colon without any evidence of bowel obstruction. So that's important, that it has to be both the small bowel and colon. It can't be one or the other. All right. So a little bit of background on postoperative ileus. It is also akin to the same way of saying it as adynamic ileus. You might see that on op reports or on radiology reports, but they both mean the same thing. Just so you are aware, different segments of bowel wake up at different times. The small bowel wakes up fairly early, 1 to 2 hours after surgery. The stomach wakes up 1 to 2 days after surgery, and the colon is the latest, which is 3 to 5 days after surgery. And just so you know how big ileus is that it costs Medicare about $750 million a year, approximately $1,500 per patient in the U.S. annually. So, if we were to avoid post-op ileus, we could be saving the taxpayers quite a bit of money. As far as how it comes about, our bowels work with many different types of nerve systems. One is intrinsic to the bowel, meaning the bowel itself has nerve systems and muscles. Prevertebral is like sort of the autonomic system, and then your long spinal nerves, which has to do with our perception of the pain and what's going on in the abdomen. And so fortunately, the long spinal nerves are the ones that we can disrupt for pain control, and if we were to disrupt this nerve center, it won't affect your bowel nerve center. They're sort of connected but separate. And so, for example, if we were to use a spinal nerve anesthetic, it would control pain but not cause ileus within the bowel. It's been shown that stress response that activates inflammation can inhibit bowel nervous systems. And then, interesting enough, our bowel health can also affect ileus, meaning that if you have good organisms in your colon tends to be healthier and can come back sooner. But if you had like overrunning of C. diff, let's say, then you're going to have ileus. Okay, so that's sort of the background on what the physiological aspect of the bowel causes ileus. All right, so another question. Which one of these is most risky, which puts a patient at most risk for ileus? Is it bariatric surgery, head and neck surgery, a complicated emergency laparotomy or an open surgery with a sigmoid resection, or complex breast surgery with implants? So we'll give you a couple seconds. So yeah, I think you guys hit the nail on the head there. Certainly open, complicated, emergency, like all of those words put a patient at high risk for ileus. And colon resections, especially towards the end of the colon, tend to be more ileus-inducing than if it was like the right colon, for example. Upper GI surgery elsewhere on the body doesn't cause as much ileus except for spinal surgery, because remember, the long spinal nerves are affected in that area, and so that could put you at slightly higher risk for ileus. All right. So as far as why ileus is happen, here are the risk factors. We went over them in the question: open surgery, lower GI surgery, retroperitoneal surgery because it affects the parasympathetic and sympathetic nervous system, use of opioids and other drugs like, sometimes they say gabapentin, muscle relaxant. Basically, if a drug relaxes the muscles on the outside, it's also relaxing the muscles on the inside. Length of surgery has been known to increase the risk of ileus, and then patient-related factors like if they're diabetic, they're overall unhealthy, they have an inflammatory process going on, if they're older, or if they're just overall, otherwise unhealthy. That puts you at risk for getting ileus. Other risk factors are, hospital kind of acquired risk factors, like if they're dealing with peritonitis, if they're dealing with a trauma, if it's the emergency surgery, if they have heart issues, because, perfusion to the bowel affects their ability to work. So if your heart and lungs aren't working very well because you have, let's say, a pneumonia, then you might have an ileus. If you have bleeding or if you have some sort of cancer going on in the bowel area, that'll also cause ileus. And then, as we know, electrolytes can cause ileus because electrolytes are closely involved with how muscles and nerves work. And if our muscles and nerves are not working very well, then you could have an ileus. All right, next question. How do you identify postoperative ileus? You take their rectal temperature. Patients have nausea and hiccups. The patient complains of abdominal pain even after IV pain medicines are administered, or the patient refuses physical therapy. So let's see. Ooh, that must have been a little harder question. Okay, so the answer is patient has nausea and hiccups. And so if a patient complains, and this is why I put this response down, is that if patient complains of abdominal pain and you give them IV pain medicine and it's getting worse and worse and worse, that is an alarm to let your doctor know that that's happening, because that tells us there's something more catastrophic happening in the abdomen than just a postoperative ileus. Postoperative ileus tends to be more benign. The patient may complain of pain, but you give them IV pain medicines or oral pain medicines, and it seems to go away. That's sort of a more ileus kind of thing that is not as critical as, like, I have abdominal pain and, I give you a bunch of pain medicines and I still feel a lot of pain. That is a red flag to let the doctor know. All right, so just reviewing the signs and symptoms. The signs are the abdomen may be distended and it may be tympanic depending on the body habitus, but it's just not too tender. It's just, they just look bloated, okay? And they may have some tenderness if it's really distended, and they may have absent or hypoactive bowel sounds. As far as the symptoms go, they're usually vague. It's diffusely tender. There isn't a focal area of tenderness. There's like a fullness sensation or a bloating sensation. They might have vomiting, hiccups. They might complain of reflux pain that's getting worse, and they just don't feel like eating or drinking anything. They may describe the pain as like a crampy kind of pain that kind of comes and goes, like gas pains. And what's interesting is that even if they're having flatus or stool, you could still have ileus. So just because you're having, farting and having bowel movements doesn't mean that you don't have ileus. You could still have some of these other symptoms like nausea and vomiting, suggesting that their bowels are sort of woken up but not fully woken up, and that is still considered a postoperative ileus. As far as the differential diagnosis, meaning like what else could it be besides postoperative ileus? It could be a pseudo-obstruction, because remember I said ileus involves both the small bowel and the large bowel. And so you could have an ileus of pseudo-obstruction, meaning that the colon is not working. Especially true for bedridden folks or psychiatric patients where their colon is just doesn't work. And it may look like ileus, but it's rather, a colonic inertia situation. Patients who have collagen vascular disease or some sort of nervous issue or nervous system issue, or have neuropathy, they're diabetic, and they have gastroparesis and that kind of stuff, is considered a pseudo-obstruction, not necessarily an ileus. And they'll have like persistent distension, meaning they came in distended. Like they have this underlying condition that is causing this issue, and it's not necessarily a postoperative ileus. The other differential diagnosis would be a mechanical obstruction, meaning that there's some sort of adhesion or mass or an obstructing thing. The bowel is twisted. And this is a situation where the pain, they complain of pain, and it's just the pain won't go away with medication. This would be concerning for a mechanical obstruction. And they would complain of crampy pain that seems like it gets worse and worse and worse. It's not a pain that like kind of comes and then it goes as quickly as it comes. It seems like it comes and then it just stays, and it's like getting worse and worse, and the crampiness is getting worse. And so that would be suspicious for a mechanical obstruction. And so we have to sort of rule these two etiologies out before we can say, yeah, this patient just probably has a postoperative ileus. So now that, that's a segue into how do you work these up? How do we rule out the other two etiologies to make this diagnosis? One of the things that we do is we do a set of labs. We do a CBC to see if there's an infection or if there's evidence of bleeding. We do a CMP to look at the electrolytes, because remember, electrolyte balance is helpful in promoting bowel health. If they have kidney disease, like if their creatinine is going sky high, that's probably a cause of their ileus situation. If they look malnourished, if they have liver disease. Sometimes we'll get a CRP just as an inflammatory marker to see if there's some sort of infection going on. And then we check the magnesium and phosphate, and that's most important in the muscle cells. And then the phosphate, is part of ATPs. If you can remember your biology, ATPs is our currency for energy. And so if your phosphate's low, that means your ATPs are low, and that's an indication that maybe you're just not nutritionally optimized. And then we can get some imaging studies. The first line usually is a KUB. I'll order a KUB if they're nauseated or having some vomiting. And then things aren't just moving the way it should be. And then if the KUB is not very revealing and we can't figure out what it may be, then we'll get a CT. And if we can get it with IV contrast, that's preferred. And if they can tolerate even a little bit of PO contrast, that would be preferred as well. I like to do a little bit of PO contrast because if it is just ileus, the PO contrast or the gastrographin sometimes help relieve the ileus. So as far as what it looks like, so these are two examples of picture of ileus. What you can see is both the small bowel and the colon is dilated. And that's what we look for ileus, is that if we just see that the colon is dilated, then we know that this is probably a pseudo-obstruction and that the colon is sleepy and there's some sort of underlying colon issue. If only the small bowel is dilated, then we worry about, is this like a small bowel obstruction situation? But if both the small bowel and the colon is dilated, then we can say, you know what, this patient just had surgery, experiencing some nausea, we ruled out infection, kidney disease, and all that other stuff, and, we see this picture, we can just say, all right, yeah, this is probably just a postoperative ileus. All right, another question. How can you help your patient with ileus? What can you do to help them through the ileus process? A, give your patient IV narcotic pain medicines. Leave them alone in the bed in a dark room and hope that it goes away. Try to convince your doctor that really your patient needs their Foley because, they have this ileus situation. Or provide education and reassurance. And, all right. So the best thing you can do is provide education, let them know what what it is and provide reassurance. You don't want to convince your doctor that the patient still needs a Foley, because it's my secret way of trying to get the patients to move around, because if they don't have their Foley, they have to get up to go to the bathroom. So no, that's probably not a good way to educate your patient. All right, so the reason why you want to reassure them and provide education is because really the only thing that we can do is to wait. We just have to wait for the body to get back online. What we do is to try to minimize the things that put you at risk, meaning like if you have a pneumonia, we treat the pneumonia. If you have kidney disease, we try to give you Lasix and get you to pee a little bit more. We as providers can sort of minimize the risks, but we can't do anything to expedite healing from the ileus. It could take as little as a couple of days to sometimes over 2 weeks. I've sat on patients after a Whipple procedure for over 2 weeks waiting for their bowels to wake up. And again, Whipple is a big surgery. It's usually an open surgery. It rearranges their bowel. And of course, they're going to have an ileus, and all we can do is wait. And in that time, your job is to provide reassurance that this is fairly normal and that we are treating everything that we can that can prolong the ileus, and that we've ruled out things that, other things that are more serious. Let's see. Sometimes we might ask you guys to put an NG tube in, even if it looks like they're not vomiting. And the reason being is that we might get a KUB and the stomach's really big. And when the stomach's really big, it just makes the patients feel very nauseous, and it just makes them feel not great. And it's amazing, you drop that NG tube down and decompress the stomach, and they're not feeling as distended anymore. They're not feeling any nausea anymore. And all of a sudden, the bowel just wants to wake up. And so, you might ask me, like, why are we putting NG tube down? The patient is not vomiting. It's because for some reason, the stomach being enlarged, if we decompress it, the body's like, oh, I need to get back online, and it seems to shorten the ileus. I might keep a diet going even with the NG tube in place. I might allow for sips and chips. Just the pure fact of something going down the throat seems to activate the reflexes that wakes up the bowels. Some centers have shown that dropping a feeding tube down and doing post-pyloric trickle feeds seems to activate the small bowel and the colon to wake up. So I've never tried that before, but I've read that that's something that some people do, and it's been shown to work, to decrease the time of ileus. But the other thing that I do is gum and hard candies, and I tell the patient this, and when I was a resident, we could actually order gum and hard candies from the pharmacy, but I don't think that we have that here. So I ask patients' family to bring in, gum of their choice or some hard candies, whether it's, if they're diabetic, I just say get sugarless candies. And like I said, something about chewing and a little bit of sugar and the fact that stuff is going down the esophagus activates the parasympathetic reflexes for the bowels to wake up. There has been some thought that activity levels can shorten the ileus, but there's been equivocal evidence, meaning sometimes it seems like it has some benefits, and other times it seems like it has nothing to do with resolving the ileus. As far as upfront things that I do to prevent ileus and my partners do to prevent ileus is put them on IRIS protocol, especially for bowel surgery. You'll see colon surgery patients being on this ileus protocol. So what we do is that we put them on clears right away. We have them drinking and sipping, and even if they were to have a little bit of vomiting in the beginning of their post-anesthesia area, we will continue to keep them on clears, because usually the nausea vomiting is related to the anesthesia medicines and not necessarily to ileus. We might have them sip on high carbohydrate fluid like apple juice, for example. You know, all the clear liquid trays have high sugar content, and that seems to get the bowels moving. We try not to leave NG tubes in place after surgery, even if it's bowel surgery, because it's been shown that just having the NG tube after surgery seems to bring on ileus. We try to get them moving around as soon as possible. Another thing that we do is that we restrict intravenous fluids, meaning that we try to limit fluids in the operating room. We ask anesthesia, hey, let's not tank these guys up a lot, because, you know, bowel edema will cause ileus. And then on the floor, they might be only running at 50 mLs an hour. And you're probably thinking, wow, this patient probably needs 100 mLs per hour. Why is this patient on 50? And it's because we're trying to limit the amount of fluid so that they don't sequester this fluid in the bowel, causing the ileus. So 50 mLs is pretty standard for me. We try early oral feedings, meaning that, you know, after 12 hours of clear liquids, if they're tolerating that, we just immediately let them have more solid foods. And what I would encourage is start with toast and crackers. Because that's sort of calming to the stomach. It has a little bit of carbohydrate, it has a little substance to it, and then move along. And generally speaking, my bowel patients will be ultimately on a low residue diet, a diet that's sort of easy to digest. And I know many of you have heard me say this. A low residue diet is my side of the fork diet, meaning that if you can cut the food with the side of the fork, it's probably okay for you to eat right now. And so that kind of simplifies things for the patients a little bit, so that they don't get all caught up in the whole low residue diet situation. And then try to limit opioids, because opioids have been known to cause ileus and constipation. Sometimes I'll put them on 24 hours of acetaminophen or paratomal anti-inflammatory agents. If they're a candidate, they might be on scheduled Toradol. And then if I can put an epidural catheter in, that's been shown to be most effective in avoiding postoperative ileus. There are some medications used for either prevention of ileus or expedite the resolution of ileus. Two of them are called Relestor and Interreg. I've used Interreg before. Studies show that it's equivocal and it's quite expensive, so that has kind of fallen in favor. I know that we have Relestor in our pharmacy. The only issue with the Relestor that I don't like using is that it's can increase their pain, because it blocks both the bowel receptors as well as peripheral receptors, and so it's kind of like giving them naloxone. You know, it kind of makes their pain increase. So I try not to use that unless they're kind of far out, like maybe a week out from surgery and we're still dealing with an ileus. I might try the Relestor a little bit. I can try some prokinetics. Reglan classically is used. Sometimes I'll even put it as a primary to nausea. Sometimes I do avoid using Reglan, because especially for older folks, it can have some neurological effects. And so, I try not to use it for older folks, but it has been used safely for older folks. You just have to watch out for pyramidal kinds of side effects, meaning abnormal motions or memory loss and that kind of stuff while you're having them on it on a scheduled basis. And then erythromycin, which is an antibiotic, has been shown to be prokinetic as well. And I don't use it as much because the Reglan is pretty good at getting things going for people. All right, so the last little bit I wanted to talk to you about ambulation. And I know, studies have shown equivocal effects on postoperative ileus, but it has secondary effects that are very important for our patients. It's been shown to reduce post-op pain, meaning that, their bodies went through surgery, they have a big incision on their abdomen maybe, or maybe they're little incisions, their muscles have been kind of moved around a little bit. And the more those muscles work and get back online, the more they feel like, oh, we can handle this pain. It's okay. It's not catastrophic. We're not dying here, And so ultimately what it results in is that they need less narcotics. And if they need less narcotics, then, you take away that risk factor for ileus. It strengthens muscles and joints, and it promotes an overall feeling of, you know what? I'm okay. I had this surgery. It hurts, but I'm okay. I'm going to get better. And that has a huge effect on the patient's well-being. Just the fact that, I feel okay. I can stand up today. I could sit up to a chair and it's okay. I've walked the halls today. That makes patients just feel better overall. And as you know, if you can get out in your day and go for a quick walk, somehow your afternoon seems a whole lot better, right? It's been shown to reduce hospital stay. So they've shown that if you can add 600 more steps a day over the course of their stay, it reduces their hospital stay by up to 2 days. They get out of the hospital 2 days earlier. And again, it's this feeling of physical well-being, like, hey, I can get up and putz around at home just as I'm doing in the hospital. So why am I in the hospital? And so that gets them thinking like, hey, I can do this at home, Obviously, we all know that early ambulation is important in preventing blood clots, pneumonias, DVTs, and so you reduce those risks. And if you get a blood clot or a pneumonia, it puts you at risk for ileus. So even though early ambulation isn't directly related to ileus, it's indirectly related because it prevents these things that puts you at risk for ileus, if that makes sense at all. It improves overall balance, posture, coordination. It makes us feel like, you know what? They can do this at home. It assures the doctors, it assures the nurses that, yeah, this patient can do this at home. It's been shown to reduce constipation. It's been shown to reduce gas pain. So if they're feeling gas pains from ileus, get them up, move them around, and that might help with their gas pains. And I can't, stress this point. It just improves your mood. It improves self-esteem and the feelings of, yes, I can do this at home. And if the body's feeling like I feel good, then, the inside of your body is going to feel the same way. It's going to be like, hey, I better get back online because this body needs to start moving, getting back to normal. And then it improves blood flow. And that's important because healing requires blood flow. If you don't have good blood flow, healing won't happen. And so when you get up and move around, it improves the blood flow to the areas where it's needed, which is at the wound sites. And so, all this put together, you have to get your patients to move around. And, some patients might fight back a little bit. And the best thing that you can do is provide education and say, hey, the reason why I need you to get up and move around is these reasons. It's going to help you get better. If you lay in that bed and, not do anything, it's going to make you more depressed. Your body is going to, not feel right. Your body's going to hurt. And then when your body hurts, your mind's not going to be where it's supposed to be, and it's going to get depressed, and then you're going to get a depressed spirit. And, I know you've heard me say this, is that, we're just not just one thing. We're not our surgery. We're not our cancer. We're not, we're three things. We're our mind and our body and our spirit. And, when I talk about pain control, it's those three things. Your body may feel the pain, But if your mind is clear and thinking about the pain and making the pain more logical, then your body is not going to make that a big deal and, cause you to ask for more pain medicines and to slow down your bowels. You're going to say, okay, this is fairly normal. I can do this. I can work through this pain. My spirits are good. I'm in a good mood. It's going to be okay. Maybe I don't need that pain medicine right now. So again, we're treating the whole person, and early ambulation definitely is a way that we can treat the whole person. Oh, thank you. Any questions?
Can you see this?
Let's see.
Do you want me to read it?
Yes.
Can the CRP be falsely elevated due to the surgery?
Absolutely, because surgery does provoke an inflammatory response. And, it's when we look at a person, again, there's not one thing that we look at. CRP is just one value. We would have to look at all of the values that are taken at the same time. Your CRP may be elevated, but your white count's normal. So is the CRP significant? It's significant in that, yes, you've had surgery, but I don't think that it would be significant in terms of like there's an infection going on, for example. And then you have to kind of trend it, meaning like, okay, we have one CRP. What's the next CRP? 24 hours later, is it going up? Is it going down? Is it staying the same? And so CRP is important, but it's part of a bigger picture importance.
Has the increased use of GLP-1 medications impacted how often this occurs?
Absolutely. I should have put a slide on that. Okay, so to give you an example, I had a patient who needed an upper endoscopy because she was having some upper GI issues. And I had said to her, I'm like, I bet it's your GLP-1, your Mounjaro that you're taking, but let's make sure that there's nothing else going on. We had her stop it a week before my procedure. And when I went in on the day of the procedure with my endoscopy, she had a full meal in her belly. And I went out, and we actually had to kind of abort the procedure real quick because she had a full belly. There was a risk for aspiration. And I went to the husband. I said, well, when's the last time she ate or drank anything? She's like, well, it was about 5 p.m. last night. And then I said, did she have pepperoni pizza and some sort of peach thing? And he's like, yeah, she had a pizza and a peach cobbler. And I was like, yep. That was still in her stomach, like nearly 16 hours later, because I think her procedure was around noontime. So she had stopped eating about 6 p.m. the last night, and noontime the next day, she had a complete meal undigested in her stomach, and she had stopped her Mounjaro a week prior. And so that tells you, how strong that this works. In fact, Dr. Kincaid was telling me one of her partners had to operate on a patient that started Mounjaro and basically killed her bowels. Like her bowel, like the blood supply was, somehow disrupted, that she is now, they had to remove a large portion of her small bowel. And so is that going to be everybody? No, it's not everybody. Some people tolerate the Mounjaro very well. But yes, it does impact ileus. Because when you come in for emergency surgery and you just had your Mounjaro shot yesterday, and I have to take out your sigmoid colon, your bowels are a little bit asleep from the Mounjaro, and it's going to not only cause you the ileus from emergency surgery, but now you have this other medicine on board that literally, stops your bowels from working normally. So hopefully that answers your question. A long way around.
When should the nurse be concerned for screening for an ileus versus attributing nausea to related to anesthesia or medication?
Yeah, I would say safely for most of our cases. Obviously, the longer the anesthesia, the longer the recovery time because they get more anesthesia. But, most of our cases are less than 3 to 4 hours in length. So in that case, I would say about 12 hours is probably reasonable. Certainly 24 hours is very reasonable. So, when I just had a patient who went upstairs after sigmoid colon surgery, and she had a little bit of vomiting episode a couple hours after her procedure, and I wasn't that concerned. I was like, well, you're probably just waking up from anesthesia. Your stomach wasn't quite ready for, the sips of clears. And then by the next morning, she's like, yeah, I've had some clears overnight, and I don't have any nausea right now. So, anywhere from 12 to 24 hours is probably where I do the cutoff for postoperative nausea.
I think that's all we have.
All right. Well, thank you, and hopefully you took home some valuable information. And the reason why I want to provide this information is that it's sort of your job to provide this information to your patients. And the more information that you have for your patients to help them through this period, which can be very frustrating. Postoperative ileus is a very frustrating thing because the patients want to get better and they're like, what can I do? And the only thing that really you can do is provide this education and to reassure them. And then to, make us doctors accountable by making sure, like, did we rule out infection? Did we rule out obstruction? Because we're not perfect. We can't think of everything all at once. And it's always helpful if, all you guys out there that are listening, know this information so that you can help us sometimes, to rule those things out and make sure that we're not missing things. So not only are you being helpful for your patients, but really you're being helpful to us. Bye.